Center for Lecture Series. My name is Nadia Safanili, and I'm a postdoctoral fellow and research scientist in the Division of Primary Care and Population Health in the School of Medicine here, and I'll be moderating today's discussion. So before we get started with the presentation, I wanted to share a few announcements. The first being that the Stanford Lean Conference is on campus and begins tomorrow. It's a 2-day conference, and you can still register if you'd like to attend. There are 1-day and 2-day registration prices, so even if you can only attend 1 day, please do check it out. And there's more information here on this slide with a link. So we hope you can join us. Are there any other announcements today before we introduce our presenters? Great. Well, I am so honored to introduce our speakers today. We are thrilled to welcome Dr. Nazleen Bharmal, Kate Britton, and Erica Higman. Dr. Bharmal has been the inaugural Chief Health Equity Officer at Stanford Health Care since September of 2024. Previously, she was the Associate Chief of Community Health and Partnership at Cleveland Clinic and the Director of Science and Policy in the Office of the Surgeon General at the U.S. Department of Health and Human Services. Dr. Bharmal practices primary care internal medicine focused on disease prevention and health promotion, and it is a true honor that she is with us today. Ms. Britton is the Manager of Accountable Care and Population Health Transformation at Stanford Health Care. She brings over 15 years of diverse healthcare experience, including previous roles managing the population health department of a critical access hospital and rural health clinic, as well as experience leading teams globally in collaboration with ministries of health in Africa, the Middle East, and Asia. Ms. Higman is Senior Quality Consultant for Accountable Care and Population Health at Stanford Health Care, and she brings 10 years of diverse experience in large academic medical centers, including previous roles in quality assurance and in performance improvement at the University of Pennsylvania and as a social worker at Penn Medicine. We are thrilled to hear from you all today and are so grateful for you joining us, and we look forward to your presentation on health-related social needs screening and response at Stanford Health Care. I will turn it over to you all now. Thank you.
Thank you, Nadia, for that introduction. And I just want to also give a great thank you to Kate and Erica. You'll be hearing some of the much work that they have also helped lead in partnership with Stephanie Bowen, Rahul Goyal, and Ashley Hortok. So happy to be here to represent it. Okay. So give me 1 second. Can you guys see my slides? Yes, very good. So we're going to be talking about health-related social needs screening and response at Stanford Health Care. This is true quality improvement. So we are in the middle of this and we are sharing where we are in this journey. So our objectives for this session are to summarize the current state of social needs screening and response at our institution, the adult healthcare system, to discuss our opportunities to expand our screening efforts across our care continuum, and then describe opportunities for closed loop referrals. And if you don't know what that means, hopefully by the end of this presentation, you will understand what that is. Very brief background. I suspect many of you know that evidence shows that 10 to 20% of a population's health is really impacted by the clinical care it receives, usually quality to care and access to care. Much of a population's health is really determined by their physical environment, their health behaviors, and social and economic policies. Sometimes these are all lumped together as social determinants of health or social drivers of health. They are the conditions in which people grow, play, live, and work. They're the root causes of health issues, which means they're very, very upstream and very hard to change. And they're shaped by a wider set of forces, including economics, social policies, and politics. I just want to share you this figure. It's a little outdated on the right, which is in 2020, the federal government recognized the importance of SDOH in the health of our nation, and so made this its own domain. And within SDOH, they have 5 different areas that include, yes, health and healthcare, the green one, but also social and community context, education, economic stability, and neighborhood and built environment. So it's also how we, on the federal level, measure the health of our nation. Now, this is a figure from Kaiser Family Foundation, and this is just to root to you why we're talking about health-related social needs. So social determinants, social drivers of health are really these big domains, often what I consider policy domains on that top row. So economic stability, your environment, education and food, social and community context and healthcare system. And these big things affect, there's a lot of evidence to show that they affect the health outcomes that you see on the bottom. Morbidity, mortality, life expectancy, expenditure, status, functional limitations. But how our patients and families experience this big domains of social determinants of health are what you see in the vertical boxes. So around economic stability, it's, does the patient have employment, disposable income? What are their expenses? What are their debt? What are their medical bills? What kind of support do they have? And so these are what we consider health-related social needs. We, I will tell you, are not screening for all of these needs, but we are screening for a small portion of them. But just to give context about how individuals experience it, and that's the language we're using today. Our current state, we're going to transition and I'll share a little bit about our current state about health-related social needs at Stanford Health Care. So first, because of a regulatory requirement by CMS, Centers for Medicare and Medicaid, we do screen every admitted patient or inpatient for health-related social needs. So nurses screen all admitted adult patients. They are asked about 5 social needs. This was part of the regulatory requirement. One is about interpersonal safety or violence. So they ask about abuse, and then the other ones are any difficulties in these other domains: accessing food, housing instability, transportation barriers, or challenges with utilities. And if they say yes, then there are more specific questions that are required to be filled, and those relevant questions are asked. Now, they're also asked an additional question, which is if they'd like to speak with someone about their difficulties. And if they say yes, then social work is notified or consulted. And then here's a big headline: social work reaches out to all patients with positive social needs. So this is sort of our flow diagram. Again, we're screened for social needs at admission by a nurse. Patients who screen positive, the top box or the bottom box, can say yes or no to social work support, but regardless, social work is going to reach out anyway to these admitted patients to discuss their social needs and help with appropriate resources. So this is what we know. What we don't know is if patients reached out to that resource and if that unmet social need was resolved. So hold this slide in your mind, we will come back to this. And then from what we know, I've shared with you how we see it on our dashboard. So this is our dashboard. It is for fiscal year 2025. It's not the full fiscal year. It's 11 months of it, from September 1st, 2024 to the end of July. And you can look at this, but I'll go through it. In summary, we've screened 24 patients are screened, again, all focused on inpatients. We have a 90% screening rate. Among those that are screened, a 4.2% positivity rate. So in absolute numbers, that's about 1,000 patients. And then among those that say they do want support from social work, that's about 67.5% of those that screen positive. And then some other things, you can see some absolute numbers regarding our screening summary. This is very interesting, our needs distribution. So how many patients have one social need versus how many have all 5. The prevalence of those needs, our trends, the trends around positivity rates, and so forth. We also can see this data stratified, you can't see it here, but by demographics, by what discharge division or what sort of area in the hospital. Are they in hospital medicine? Are they admitted to hospital medicine? Are they in general surgery? Are they oncology? So we can look at that. And we can see how social needs are in relation to our admission rate and average length of stay. So very helpful for us in terms of understanding the impact of social needs among our inpatients and among some other metrics important to our hospital. I'm happy to share this dashboard and give access to anybody who is interested. Just send me an email after this. Okay, so we knew that there was a group that had been working on social needs screening and response, and we knew we wanted to move from the regulatory requirement to a different direction around this recognizing the importance, again, of social needs on our population's health. So we embarked on a patient journey mapping exercise, and several themes came out. Just a few that I'll read: the visibility of screening and response across the care continuum. So our ambulatory setting, our ED setting, our interventional platform, which is sort of code for our surgical areas, in addition to our inpatient units. Recognizing that question mark box, when we give patients resources, what happens? So we'd love a closed loop referral to any group that we are referring to. The technology integration for screening, referrals, and follow-up. And for any of you who may work at Children's, you may know, or Packard may know, that they have integrated a technology platform called Find Help to do electronic referrals from the inpatient setting directly to a community-based organization that's accepting those electronic referrals. The adult health system is not yet integrated that yet. Partnerships with community-based organizations and patients and families, and then recognizing the resource evaluation and support that we need to be able, if we want to expand this work, for screening and response. And we did this, I would say around February, March, January, for the first quarter of calendar year 2025. And we recognized very early during that time what our potential barriers would be. Resource needs for various initiatives. We're all going through some interesting financial challenges. And then also thinking about the changing political climate and policy regulatory impacts. So again, the adult healthcare system started doing this because of a regulatory requirement. That regulatory requirement is going away in 2026. But Stanford Health Care has committed to doing screening for our inpatients, as well as other patients in other care settings, regardless. We might just think about what the frequency of that might be as we move forward. And I'm going to turn it over to Kate, who's going to share our first major goal, which is efforts to expand social needs screening across our care continuum.
Thank you, Dr. Bharmal. If you could go to the next slide, please. Our team has really been focused so far in this initiative by conducting a current state assessment, and we're also working on a pilot project. So in terms of background, as you just heard, the inpatient setting had a requirement, although we don't have a requirement. As part of Stanford Health Care's health equity strategy, we will be implementing HRSN screening into ambulatory pilot sites, not only starting in FY26, but starting in the next couple of weeks. So that's very exciting. We'll be hoping to better understand the patient population needs and health outcomes. So under context, we did some lit review, we did a lot of interviews and research to better understand kind of the world of HRSN assessments around the country at Stanford, what HRSN capture looks like, what it looks like in Epic, what different clinics are doing, what kind of interest did stakeholders have to do this assessment, any barriers or concerns that would come up, potential pilot site recommendations, staff resourcing or lack thereof, depending on the clinic, and what the patient needs might be. Our first findings were that most of the respondents reported that they were doing some kind of standard social needs assessment, and that was generally in the area of interpersonal safety, especially in SHC primary care clinics. And respondents identified the highest patient needs as around transportation, housing, and medication affordability. And when we implement our pilot, we will find out a little bit more about those needs. So the recommended actions based on the lit review and the CSA, or current state assessment, were to implement a pre-visit questionnaire via MyHealth at an 8th grade reading level, to have social needs resources available to all patients, and to pilot in both primary and specialty care. So I'll go into a little bit more detail there as we go through the next slides. For an overview, we spoke with 27 different individuals in 20 different departments across Tri-Valley, SMP, SHC, in both primary care and specialty. And we heard a lot of really interesting information. And I do want to share some quotes that we heard. So from one person, they said, if it ends up being in the form of a My Health questionnaire that's filled out prior to the visit, then I'm very, very much on board with that plan. The more that we can get done asynchronously before the visit, the better. Also, to have some resources at the ready where you could just pull it into the note with a link to their visit summary, that could be helpful. And then lastly, knowing the time commitment of addressing HRSN with patients in clinic, our team would see this as a good investment. This would solve some day-to-day challenges. So there was a lot of interest from the interviewees in this assessment. Do you want to go to the next one? There was also some concern around resources. So we wanted to better understand staffing and training and any concerns there. Essentially, clinical staff responded that they were overwhelmed by the volume of visits and questionnaires. Also, that if this were something that we wanted to do in the clinic, there would be a need for a dedicated role, that there's not really capacity right now. And then in terms of training, there isn't very much standardized HRSN training taking place. In the ED, residents are receiving some informal education, but not in all of the other clinics. The exciting news was that there was really already a strong basis of knowledge around HRSN impact amongst the interviewees. Um, and like I said, everyone was pretty excited. One person said, "This is fantastic. Thank you so much for being part of this very important charge. I think this is wonderful in terms of it's very uniquely Stanford. It's not all about regulatory requirements. It's the right thing to do. I think we can really have a big effect." And then another interesting note was this one. Another thing that's important to address is often patients will be embarrassed to respond accurately when someone is personally asking them those questions versus if they're privately answering them through My Health. So the respondents really did inform the way that we wanted to go about the pilot and making sure, okay, the first opportunity is going to be through My Health, and then clinics can make a decision later if they also want to ask those questions in person. And then just to add to the staffing, I wanted to share kind of where all of our social workers and LCSWs live. So you can see that there are social workers in primary care and specialty, but this is SHC only. And a couple clinics actually have more than one social worker, so they're very lucky. If you want to go to the next slide. Okay. We asked about barriers and concerns because this is a new initiative. There's always some worry about how this might look. Really, the primary barriers that we were hearing about were time during visits. There's already so much being asked and so little time in the visit. That was a real concern. And then also just knowledge of available resources. People were worried that if we ask these questions and somebody responds with, I don't have enough food for my family this week, like, well, I don't want to be responsible for that. I need to know what to do in that instance. So we kept that in mind with the pilot planning. So for availability and knowledge of resources, we're establishing a workflow to react to not only positive responses, but to any responses, even if they're negative. The patient will receive resources, and we've prepared a lot of training and resources for clinic staff. So we wanted to respond to that concern and just be able to build the confidence of staff to be comfortable in doing this. And then around time during visits, we're doing the questionnaire pre-visit and providing resources to all patients in advance of visit. So if a patient has a need, they can address it before they even get to the clinic, so that will hopefully take, it won't take the time away from clinicians. Another interesting comment that we received was language is always one concern, whether they're English, Spanish, Chinese speaking, different cultures may or may not tell you their social needs. So that also kind of informed our decision to make sure everybody gets access to information if they have a social need. If you want to go to the next slide. So based on the current state assessments, our operational recommendation is the following: to implement a self-proxy or screener-administered My Health questionnaire, and to make sure that we have data feedback and monitoring through a dashboard and other reporting in place so that we can share this with the pilot sites. We'll be doing this in both primary and specialty care for an easier and more sustainable spread across ambulatory settings. So those sites will be Stanford Internal Medicine West, comprehensive neurology, and endocrinology. And we'll be working with the pilot sites to determine what would be the best visit type and the cadence of the questionnaire. We'll be working with teams on PDSA cycles, and we'll be tracking traffic on Find Help to see if there's any difference before and after the pilot. And then I think the next slide, this is the pilot timeline. So we completed the kickoff and planning last month, working with different operational and medical leadership to talk through the pilot, establishing expectations and guidelines, developing staff education and OPLs, and then working through different process maps. Right now, we're in the test and implement phase, so we'll be going live in the next couple of weeks with the 3 different pilot sites. We'll be working closely with the teams to run PDSAs and having meetings with them regularly. We also want to have a collaborative session with all of the pilot sites together for lessons learned, and we'll be conducting data monitoring and feedback. Toward the end of the year, we'll be in the control and sustain phase where we'll be finalizing all the lessons learned, finalizing a playbook to be used for spread. We'll be conducting a pilot site sustainability checklist, and we'll be meeting with ambulatory quality in preparation for transition. And then in January, February, that's when we will transition to ambulatory quality and begin to deploy across ambulatory clinics.
Thank you, Kate. And I just want to say thank you also for the presentation, but also hold us all accountable for this timeline. This is a mock-up of what we're thinking about for the My Health. For those who don't know, My Health is our patient portal on the adult side, the My Health questionnaire. We know this is not the best way to reach all patients. It is a first step, and it's about culture change. So this is what it would look like. The questions cannot be changed. There was a lot of discussion about having the questions asked that were validated in the inpatient, emergency department, and ambulatory settings. And we want, as Kate mentioned, we want to make sure that we have a resource regardless of how you answer this. So this red box at the bottom for help accessing resources for your needs, please visit the Stanford Health Care Resource Hub, which is a Find Help hub, where, again, very patient-driven to find their sort of social need and their zip code, or call 211. 211 is manned by the United Way, and it serves 8 counties in the Bay Area. We're also going to be sharing this before we go live with our patient and family partners to get their feedback as well. Oops. Okay, so please hold your questions related to this first section until the end. But we just want to transition to the second part. So if somebody is positive, what are our efforts around closed loop referral or recognizing whether or not patients connected with resources? So again, this is sort of the diagram that we have right now, where patients are screened, all inpatients are screened at admission by a nurse, whether they have say yes or no to social work and have a positive screen. Social work reaches out and gives appropriate resources. But what we don't know is if that patient reached out to that resource and if that unmet social need was resolved. And so to better understand this, we started a pilot program with one organization, Samaritan House. Some of you may be familiar with Samaritan House. It is a core agency, means that it helps with core services like food and housing for all residents in San Mateo County. Actually, in California, every county has its network of these either core agencies, or they may call it emergency assistant networks. And these are kind of the first stop for any resident that lives in that county. So we were very excited to partner with Samaritan House for our initial pilot. We just started, it's been about maybe about 2 months, a month and a half. And you see, we start here where our social work team, an inpatient social work team, will send a referral to Samaritan House. Samaritan House receives that request and connects that patient to resources they directly have or to an agency that can meet that. Then together they provide the necessary supports for that patient, and they document it in a system that they have internally. And then Samaritan House sends us, SHC, a regular monthly report on what the status of the referral is. And they will reach out to the patient within 24 hours of getting something, a referral from us, and hope to connect within 3 days. So in our first month, which was a summer month, 12 patients met the eligibility criteria of having a positive social need and living in San Mateo County. And these are some of the key metrics that Samaritan House needs for its work and that we are also following, including type of referral, our first contact date with the patient from Samaritan House, which agency responded when the patient was contacted, the patient's response about contact. We know that there is a attribution or trickle down effect with every handoff, so patients may refuse that next contact, and then the demographics. We are also doing sort of a narrative, qualitative work related to interviews with the social work team, with patients, and as well as with Samaritan House to see how the process has been and how we can improve upon it as we add more organizations. But among those 12 patients that were referred in that first month, needs were met for shelter, transportation, food, rental assistance, and ID voucher and cell phone. And one particular story is that among the 5 patients that were referred for shelter, 3 patients were automatically connected with shelter in what our social work, Ashley Hartog, said was the fastest turnaround time that she's ever seen. So that says a lot about having these lessons learned, which are having shared goals are critical in helping build this kind of collaborative partnership. The importance of linking to services while the patient is in the hospital. And this came up because Ashley shared with us, shared with us that sometimes when patients, when they leave the hospital, either they might not have the phone to connect with or the number, or it's not as top of mind. So to do a little bit, thinking about the timing of when we send that referral to Samaritan House, prioritizing patients without cell phones, and then recognizing that when they did connect with an organization like Samaritan House, additional resources were offered. Now, we want to think about where we want to go from here, and to better understand that, we really want to think about what does the literature say about people who have been doing this work around health-related social needs screening and response. And for this, I'll turn it over to Erica.
Thanks, Dr. Bharmal. So the literature review that we completed as part of the current state assessment was twofold. It's broken out into social needs assessment versus social needs intervention in healthcare settings. And as you can imagine, a lot of the research that was published was based on intervention, since that's more quantifiable, but we did also find some helpful tips and approaches in regards to screening itself. So over on the left-hand side of the slide, we pulled some of the best practices identified for screening, a lot of which came from successful approaches that were part of the implementation of the Accountable Health Communities model through CMS. So they were tested in the screening of thousands of patients over the 5-year period across the country. And then also related to that, CMS published a guide to AHC screening as well following the 5-year period. So some of these came from their recommendations. We have here just some examples.
Can I just pause you for a second? I hear a little bit of feedback. Am I the only one that's hearing that when you're speaking? There's a little bit of
I think we're all hearing it, Nazleen.
Okay.
I was just about to say something.
Thank you.
Oh, I'm sorry.
You might try turning your camera off, Erica. Maybe that'll help. I don't know.
Okay, I'll try that. Is that any better?
No.
Static? Okay.
A little bit of a static sound. I think it's okay to keep going. I just want to make you aware.
Okay, I apologize for that. I'll just try to run through briefly here. So some of the examples from social needs assessment and the lit review, just some of the key takeaways we have here were as follows. So first, optimization of the timing and language for initially contacting patients about social needs screening. So for example, at one academic medical center, they were texting patients links and tracked the time of day in which patients were most likely to engage with the text and what type of language was used in the text in which they were most likely to respond to. Next, as Kate mentioned earlier, having dedicated staff roles for screening specifically, which is something that came up as a theme in our interviews as well. Overall, ensuring that there's general education for staff on current community resources, how accessible those are to patients, and how they compare to different geographic areas for the staff who might not be as close to those concepts in their day-to-day work. So understanding the current landscape of social resources. ensuring culturally tailored language. So for example, accounting for different dialects and utilizing native speakers where available to identify the best language for patient engagement as possible. Accounting for patients with limited reading skills by offering an audible version of the screening was something that one center did. And lastly, using non-punitive language. So patients of different backgrounds and age demographics might respond differently to terms such as help or assistance or social services. They found that they were more likely to engage if terms like entitlement or benefits were used instead. And then on the right-hand side of the slide, moving over to social needs intervention and its impact on healthcare utilization costs. So these mainly came from multiple reviews that were done by the Commonwealth Fund looking at cost reduction in social needs interventions across the country. So they have done really comprehensive summaries of different research across the key social domains published in both 2019 and 2022. They looked at close to 90 studies total, some of which were at academic medical centers or clinics, and some of which were at community-based organizations. So just for the sake of time, I know we want to leave some time for questions, so we'll just kind of run through here several of the interventions that were looked at. So there were many studies done around the implementation of permanent supportive housing programs for patients with housing stability concerns with consistent improvement in healthcare utilization. Home modification interventions were also considered, so things such as fall prevention in the home or modifications for asthma patients, for example, both showing significant ROI yield in terms of nutrition, increasing access to healthy food, such as with things like food pharmacies, medically tailored meal programs, and nutritional counseling, also showing positive impact on healthcare costs. The transportation, interestingly, many of these studies did have small sample size with not much robust evidence, although a systematic review did determine that transport interventions such as rideshare funding was more likely to be effective when combined with other interventions. And these studies looked at several other domains such as financial counseling. They also looked at legal assistance, social isolation and loneliness, and care management. So really interesting reviews from the Commonwealth Fund and really robust research around social needs intervention. But I will turn it back to Dr. Bharmal, and again, apologize for the background noise.
Thank you. Sorry you have to do that with the static. And we have, when we share these slides, we have the references in the end, so people can also look at these. But just a really nice way to think about where we need to be going in terms of our assessments and what we know in terms of interventions that work. So sort of a playbook for the 5-10-year strategy. I'm not going to go through this. We just want, before we end, we would just want to share a few acknowledgements. We know that this work takes a lot, and I also want to just give a shout out to Purnima Krishna and Supriya Dal and Carol Yoon, who led a lot of this work with the teams. And so just thank you so much for that. Our acknowledgements for all the interviewees that Kate and Erica went through, as well as acknowledgements to our social work team, as well as our Samaritan House pilot staff, Latrice Taylor and Carly. And then we'll just leave with this slide before I stop sharing, which is these are the big questions that are really helping to think through our work around health-related social needs, recognizing AI and technology and thinking about unstructured data. How do we know the social needs and really just a patient 360 of all of our patients so we can better serve them? How do we as a healthcare system best intervene, and when should we be partnering, and how are we good partners? And then how do we know if the interventions that we are doing are effective, and from whose perspective? Our perspective, the social work's perspective, the community-based organization's perspective, or the patient's perspective? I guarantee you those are all different answers. And it'll be so nice when they coalesce. So these are sort of the big questions that we want to leave you with. And Lisa and team, would you like me to keep this slide, or should I just stop sharing? This is our last slide.
Whatever you'd like to do, we can take it down and maybe people can take a screenshot and refer to it.
We'll keep it up for a second, but yes. And my apologies if you were putting stuff in the chat. I did not have a chance to both drive and look at chat at the same time. So my apologies, I will look at that now. I'll turn it over back to you, Nadia.
Great. Thank you so much, all three of you, for such a wonderful presentation. This is such important work, and it's very exciting to hear all the movement that's happening in this space. We're going to start the Q&A portion of the session right now. So we've got about a little less than 20 minutes for questions. I did receive one in the chat already, but if you haven't already put your question in the chat, please do so now, or after I ask this question, feel free to unmute yourself as well. But we did receive one question specifically saying, could you please reflect on concerns of many patients with unstable immigration status regarding fears of disclosure and retaliation around screening positively? How can we better ensure everyone has access to resources without experiencing the fear associated with admitting that they have need?
I think that goes back to our original question, which is that the way that everyone's going to have access to that free resource or to be able to call 211, you can actually text them, but we don't want to put the text number in there also because it's not 211, in terms of if you have a need, including, whether you need access to legal aid, that those resources will be available. Now, the challenge with that is that you have to be an active user of My Health and your patient portal. So again, we want to say this is our first step into where this first array is not going to address every issue that we know comes from health-related social needs screening and response. We know that. This is our first step just to see what the uptake will be and what things we will sort of encounter that we will have to do continuous improvement and quality improvement on to better understand. But great question.
Thank you so much. And Craig, I see your hand raised. I'm going to ask one question that's related from the chat briefly before I get to you. From Maggie, do we have an estimate for patients who do not engage with MyChart, thinking about the equity implications there that you were just alluding to?
As of today, I think the different pilot sites may have different approaches. So I practice on one of the pilot sites, which is a primary care physician that practices at Stanford Internal Medicine West. I went back and forth in my own little clinic about whether or not we can just make it just a My Health questionnaire. They felt very strongly that they wanted their MAs to also screen and have hold some accountability there. I think we're going to just see how the environment of each clinic doing this. In primary care, honestly, this is our bread and butter. Whether we're actually doing it and collecting this data or not, it comes up. So, and the specialties, it's very interesting. I want to give a lot of credit to Kate and Erica for recognizing that there was specialty interest and recognizing the kind of environment that Stanford Health Care is and the importance of including them as pilot sites as well. So I think we're going to learn from that and take that into the playbook. Kate and Erica, anything you might want to add to that regarding the MyChart or My Health uptake?
I think I want to emphasize that it doesn't matter how a patient responds or if they even respond, they're still going to have access to the link to find help in 211. So if they're not comfortable responding positively, that's fine. They can still get the help that they need.
And to recognize that we know one of the steps is that it's patient-driven right now. It's not ideal for all patients. And we recognize that, and we are, again, a step-by-step process. Yes.
Thank you so much. Craig, thank you for your patience. Your question, please.
I'm sure I speak for everyone on this call to think that Stanford is very lucky to have you, Nazleen, and your team working on such an important topic. So first, thank you. I have two questions. The first question arises from your challenge to us is how will we know that interventions are effective and from whose perspective? Because I'm reminded of an unpublished project with a large Medicaid managed care plan that was looking at an algorithm to predict high cost patients and long hospital stays. And what they found from their database was that patients who answered two or more positives to questions around social needs, and particularly around transportation, were substantially more likely to become high-cost, long hospital stay patients in the years coming. So one suggestion might be is as you look at parameters to judge the effectiveness of your intervention, is to see whether or not, whether it's closed loop or whether it's just identifying high needs patients, whether or not, the prevalence of subsequent healthcare costs is different between those who are connected and those who were unconnected. And the second question I have is regarding the use of artificial intelligence and AI. You mentioned briefly about how Children's Hospital has an application called Find Help, but do you think that there is a role for using AI as a pre-visit chatbot to do an interview that becomes immediately more extensive and potentially replaces the need for social workers or a human interaction to develop a richer story about what's happening or around social needs?
So I'll answer. First of all, and also I just want to open up to anybody else because I see a lot of our team also here. First, Craig, thank you so much for what you shared about connecting this and thinking about what that might do in terms of sort of the financial aspects. So I think that's another element that we should add as we're doing this work and thinking about that. And subsequent costs. For AI, I think there's so many opportunities. So things that we're already looking at now but haven't put into place is just on the screening part. I'm hoping that in the future, My Health will just be sort of an added thing, that questionnaire, but we could find out that information from the unstructured data. A lot of this is actually being led by our patient experience and TDS team, the unstructured data, and to think about, when you send that message to the in basket, when on doctor's notes that like sometimes it comes up, but it might not be on something, that we can capture the phone call, that we can capture some of that information and give us at least some insight into who we should definitely be more targeted in screening. I'm a huge believer in universal screening. I think there's a lot of biases when you do targeted screening, and I also think it's the next step of this work. So I think it would be really helpful for that. And then the second part about the response, I think there's many opportunities for AI that can be probably even more patient-centered, more culturally responsive, more linguistically tailored than what we're capable of providing today in terms of actually meeting the needs of the patient. I did a study that we published where we looked at, during COVID, 1,000 Black men, and we put out a survey to them about their, not just social needs, but their medical needs, behavioral health needs, a whole host of needs. And 94%, we had about a 60% response rate. 94% of those that answered the survey, 60% response rate was like unbelievable, said that they had a need that they wanted us to address. But then when you actually asked them, when we gave them the resource and followed up and then asked them if that need was met, I'm telling you right now, it was a handful. So it went from like something like 600 to 5 people feeling like their needs were met. That is so much work to do in this area. And again, a healthcare institution alone cannot do it for a whole host of reasons. So I think a lot of opportunities here as we learn about our full patient context. And I do think that AI and using that on both understanding who our patients are, as well as how best to respond to them, could be a helpful next step. And we'd welcome partnering with anyone who is also interested in that. Yes.
Wonderful. Thank you so much. Tracy, I see you have a couple questions in the chat. Do you want to unmute and ask your questions?
Hi, thanks for the opportunity. Really appreciate all of this work and really the thoughtfulness and intentionality. 2 questions, just, and if you said it already, I apologize, but does SHC intend to continue requiring the SDOH screening for inpatient admissions despite the anticipated regulatory changes? And then second question is just, how have you evaluated the quality of screening given your 90% screening rate?
Yeah, it's a really great question. I wonder if anybody else on the team would like to speak about this. I'm looking at you, Purnima, if you would like to speak about this, but I will just say, yes, the answer is a yes to your first question. We have every intention of doing it. I think, Tracy, the question is whether, how frequently, like it was every time a patient was admitted. So just think about the patients that are getting admitted multiple times. Like, does that make sense? Does that not make sense? Is that patient-centered? Is it not? Like, is it a trauma-informed approach? Is it not? So I don't know. Like, I think we don't know. That's like some of the work to do. And then the quality of the screening, the team, even before I got here, has done quite a bit of work thinking about the quality of that screening rate. 90% is a very high rate. So I will turn it over in case anybody else would like to speak to that. Purnima, you went off mute. Thank you.
Yes. Thank you, Nazleen. So Tracy, very good question. So, that 90%, just to reflect on it, we started with very low screening rate, and very recently we have reached that point of 85 to 90%. But from the overall standpoint of assessing our patients' needs, I think the screening will still continue to happen in inpatient. And as you heard today, that we will expand to outpatient as well. But there is opportunity. This is not, still we have an opportunity to ask the question in a different format where our patients feel comfortable to respond. These are sensitive questions, so opportunity still exists, no question about that. But at least the screening infrastructure that we have put in place right now would actually help us build that, robust data structure to go and evaluate where we should focus our efforts on. So inpatient screening is a little bit more mature as compared to what we are doing with the ambulatory area, right? So built upon that inpatient screening, we have to learn from those, the way we are asking question, where our education opportunity lies, and where we provide skills to our own employees to handle some of these areas where the patients come screen positive for their needs. So this is where we are right now. The state of the union today is like we will continue the inpatient screening and then continue to evaluate and do the PDSA online.
Thank you, Purnima. I will add one other exciting development. So a lot of work has been done in the emergency department already. There has been a team that's been working on it. It has starts and stops. As I learned from one of our wonderful emergency department providers, patients that come to the ED are also Stanford patients. We have just signed a contract with an organization that will provide community health workers into our ED. One of their roles will be social needs screening and response. So that's also an exciting development.
Great, thank you so much. Elmer, I saw you had a question. Would you like to unmute and ask your question?
Yes. Is this going to be available as an app for patients, just like whenever they are able to access that away from hospital or after discharge or something?
Elmer, I am so sorry. If you wouldn't mind asking again, there's some construction work happening outside. I think I just missed that. Do you mind asking again?
Nazleen, do you want me to take that?
Sure.
Elmer's question is that if this is if the patient level detail will be available for download. So right now, the patient level detail is available in the Epic. There are reports, but unfortunately, we cannot download that level. But you can do slice and dice and do some analysis. But we are also, Nazleen showed you guys the SDOH dashboard that is coming up. And in that context, we can do some ad hoc data download for a specific area to review. And eventually that will get enhanced to add some patient level data along with the clinical outcomes tied to that. So more enhancement to come. But if you are interested in any particular area or service line or division that you want to drill down to and assess the opportunity there, happy to help and can connect offline.
I don't know how access will be, but I did share the link to the dashboard in the chat. Thank you, Purnima.
Thanks so much. Kate, I see you have a great question. Would you like to unmute and ask your question? I can start your question, but feel
Double
free.
muted.
Oh, there you go.
I'm sorry.
No,
Yeah, I love the idea of offering social resources to everyone. And I was wondering if you could then skip the need for the questions because everyone is having fatigue around those, but then follow it from the other end with if they're using resources, check and see if those are meeting their needs. So that was my question.
Yeah, it's a great thought. Thank you, Kate.
all right, I think we have time for perhaps one more question. Olga, I see you have the last question, if you'd like to unmute.
Thank you very much. I was actually just wondering, so first of all, it's a wonderful program, very supportive of everything that you guys are doing, and very grateful for our patients. But I'm wondering whether, so this is a patient pool, like patient actually needs to interact and begin the process. I'm wondering whether you thought about actually more proactively managing those patients who might need more help but don't have my health, or don't have the are afraid to say that they need help, but they come to our emergency department every other day because they need something. And so basically offering these services and managing those patients a little better, basically like a case manager of our multi-visit patients.
Yeah, it's a good thought. Olga.
So, Olga, I want to add is that you all have heard about the ED complex care program, which actually was working on multi-visit patients coming to ED. And the framework that they have used is having the dedicated social work and the clinical team come together to assess the need of the patient and provide a care plan that is very customized for that particular patient's needs. So the question is, the answer to your question is yes. For the multi-visit patients, when it is organized through our Sum of Variables program, one of the other team that has worked on it is the Stanford Coordinated Care Program, Kate's team. When a social work and case management team is involved, it is proactively, they are managing some of the needs of the patients through that angle as well.
Thanks, Purnima.
Yeah.
All right. Well, thank you everyone so much. Thank you, Dr. Bharmal, Kate, and Erica for a wonderful presentation.